Hello all, welcome to another episode of DrGrad. This is the second chapter of our ECG series. In this chapter, we are discussing heart block and various bundle branch blocks. We're seeing what the ECG looks like in heart block, in case of heart block, what are the different types of heart block, and we'll see what we expect in right bundle branch block, left bundle branch block, and something known as the bifascicular block and the left anterior fascicular block. All of that we'll see in detail. So heart block is basically divided into first degree heart block, second degree heart block, and third degree heart block or complete heart block. So heart block as such means it is AV block, atrioventricular block. So there is some problem in the AV node. When we talk about first degree heart block, it basically means that the PR interval is prolonged. There is no other abnormality, the rhythm is normal, but there is PR interval prolongation. As we have discussed in the previous module, our PR interval is normally extending from 120 to 200 millisecond. We can say a maximum of 220 millisecond or 0.2 second or 0.22 second. When it is more than that, it's called first degree heart block. So there is some kind of difficulty of transmission of electrical activity from the SA node to the AV node. So there is some delay. That is called first degree heart block. So the P wave is there before each QRS and they are identical. So there is one P wave followed by one QRS, one T. Again we have a P, QRS and T. So we have one QRS complex for every P wave. So there is no abnormality in the P or QRS, but the interval is prolonged. It is seen in coronary artery disease or in a setting of acute rheumatic carditis or in digoxin toxicity or some electrolyte disturbances. Coming to second degree heart block. Second degree heart block is further classified into Morbitz type 1, Morbitz type 2, and we also have some fixed ratio heart blocks like 2:1, 3:1, 4:1. We'll see what they individually mean. Morbitz type 1 is also called as Wenckebach phenomenon, and it's usually a benign condition, does not require any kind of treatment. We have then Morbitz type 2 and fixed ratio. This Morbitz type 2 and 2:1, 3:1 or 4:1, it may be something that is signaling an impending complete or a third degree heart block. So that needs to be kept in mind. So when you come across a Morbitz type 2, you have to analyze and evaluate the patient because they may herald a complete heart block. We'll see the ECG picture of all of these individually so that it becomes more clear what each of that type means. So this is Morbitz type 1, otherwise called Wenckebach phenomenon. This is the ECG picture showing the same. Here we've told what is Wenckebach phenomenon. It's a successive prolongation of PR interval until one P wave is completely blocked. I'll decode what that means. So here we have see one cardiac cycle, second, third, fourth and fifth. We'll see what is happening progressively as we come from this first one until the fifth one. See here, what is PR interval? PR interval means one wave plus one segment. PR interval means P wave plus PR segment. So this is the PR interval. So PR interval in this first case, that is from the beginning of P, that is the P wave, and this PR segment, that is beginning of QRS complex. This is a PR interval in the first case, supposedly normal in the first case. In the second one, we can see this is our PR interval. So there is slight prolongation of the PR interval. In first one, we can see it's around 1.5 large square. Here it is 2. In the third one, but all of this, first one, second one, this is the second, third, and fourth, all of them have one thing in common. That is, one P wave is followed by a QRS. There is a QRS. Here we have a QRS. Here we have a QRS. In the third one and fourth one, we have QRS. But what is happening to the PR interval? There is progressive prolongation of the PR interval. See, this is even prolonged. This is further prolonged. What happens to the fifth one? Here is an interesting phenomenon in the fifth one. There is no QRS in the fifth one. See, there is no QRS in the fifth one. We don't have a QRS here, right? So P wave is completely blocked. That is what they mean by Wenckebach phenomenon. So this is Mobitz type 1. It's usually benign condition. It does not require any kind of treatment. Coming to Mobitz type 2. What does Mobitz type 2 means? It means some of the P wave are not being transmitted. There is occasional dropping of QRS, occasional blocking of P wave, or occasional dropping of QRS. Both of that term means the same thing. What does blocking of P wave means, or P wave not being conducted means? That means there is an atrial depolarization, but that is not followed by a ventricular depolarization as it normally should happen. Right here, we'll see one diagram so that it becomes clear for you. So you can see some of them are not being conducted. That's just what that means. So here we have a P, here we have a QRS, here we have a T, and there is some aberration in the T. That is again a P. Okay, then we have QRS, we have T, P, QRS, T, P, QRS, T. Here we have a P, right? This is a P wave, but where is the QRS? There is no QRS here. So that's Mobitz type 2. That is occasional dropping or occasional blocking of the P wave. That is, some P waves are not conducted. Randomly, some P waves are not being conducted. Here also, here all the P wave correspond to QRS. Suddenly there is one P, but there is no QRS. We have a P again that has been conducted. This P has been conducted, but this P is not been conducted. Okay. Here again, we have a P, but we don't have a QRS. This P, see, this P is not been conducted. Here this P is conducted, this is conducted, but this P is not conducted. Okay. This P, QRS, T. So again, there is this P, but that has not been conducted. Now this actually means that there is one P, no QRS, again a P, QRS, again P, no QRS, again a P, there is QRS. What does that mean? You can see in this diagram, here also there is one P. Here there are 3 QRS, right? So QRS complex, how many are there? There are 3 QRS in this diagram, 3 QRS complexes. But how many P are there? See, there is 1, 2, 3, 4, 5. There'd be a 6th one which has not been conducted, right? You have a 6th one that is not going to be conducted because that is a pattern that is following. So there are going to be 6 P's for 3 QRS. What does that mean? This one here that we have is a 2:1 block. That is what the ratio stands for. The ratio means there are 2 times P waves as there are QRS complexes. So for every 2 P wave, there will be 1 QRS. What does that mean? Each of the alternating P waves are not being conducted. So this is a typical example of 2:1 hard block or Mobitz type 2 second degree hard block. some diagrams. We'll see what does this mean. We'll try to decode. Okay, so what does this mean? Here we have a P. There is a QRS following that. Here we have another P that has not been conducted. We have a third P that has been conducted. We have a fourth P that has not been conducted. Fifth P is being conducted. That means alternating P waves are conducted. So this is a 2:1 heart block. So this can be called a 2:1 heart block, which is a Morbitz type 2 heart block. So Morbitz type 2 just means that occasionally there are some P waves that has been missed. That is what we mean by Morbitz type 2. 2:1 means that is a fixed ratio heart block, which is a kind of second degree heart block. That means alternating P waves are being dropped, or there are 2 times P waves as there are QRS complexes. So this is a kind of second degree heart block. Okay, so that was second degree heart block. We had Morbitz type 1 or Wenckebach phenomenon, where there is successive prolongation of the PR interval until one P wave is completely blocked. Then we had Morbitz type 2, where there is occasional dropping of QRS complex or occasional blocking of P wave. Some of the P wave is randomly not been transmitted or not been conducted. Then we had fixed ratio second degree heart block, like 2:1, 3:1, 4:1. 4:1, what does that mean? There are 4 times P waves as there are QRS complex. That means only every fourth P wave will get conducted. There will be 3 P waves that are not getting conducted. Now coming to third degree heart block or complete heart block. That means there is no relation between the atrial depolarization and the ventricular depolarization. None of the SA nodal electrical activity is being conducted to the EB node. The SA node and the atria depolarizes separately and independently of the ventricle. So ventricle will start to depolarize and fire from its own ectopic foci, and that will have a rhythm on its own, and P wave will be atrial depolarization will be occurring independent of the QRS. So we'll have a haphazard ECG where there is no relation between the P and QRS. Suppose there be a 10 P wave and 2 QRS. There will be no absolutely no relation between P and QRS. It can be seen in an acute setting of MI or in chronic patient when there is fibrosis around bundle of His. So this is basically a problem with the bundle of His. So when the bundle of His is blocked, so there is no transmission through the left bundle branch as well as the right bundle branch. So there is no electrical activity that is getting effectively transmitted into the ventricular musculature. So ventricles will start to fire from its own ectopic foci independent of the P wave or the atrial depolarization. That is what we mean by third degree or complete heart block. This is the summary of what we have discussed so far. What is meant by first degree heart block? There is no abnormality in rhythm. There is only PR interval prolongation. So the first degree heart block means there is PR interval prolongation. That is the only thing we have in a first degree heart block. What is second degree heart block? That is Morbitz type 1, Wenckebach phenomenon. The PR interval is progressively prolonged until one P wave is completely blocked. See, PR intervals become progressively longer until one P wave is completely blocked and one QRS is dropped. Okay, they both mean the same thing. Second degree Morbitz type 2, that means there are more P waves than QRS, and we'll denote the ratio by 2:1, 3:1 or 4:1. When we say 3:1, it means there are 3 times P waves as there are a number of QRS complexes. Then we come to third degree IV block or complete heart block. That means there is no relation between P wave and QRS. P waves are not related to the QRS complexes. Okay, so these are the 3 types of heart blocks. Now coming to bundle branch block. we have right bundle branch and left bundle branch. So either of them can get blocked. So that is called a right bundle branch block and left bundle branch block. When we understand the basics of bundle branch, we have to first keep in mind this thing that I've put in a box. The septum is getting depolarized from left to right. Okay, so we have ventricles, right? So now the electrical activity has reached a bundle of His. From there it is going to the right and the left, so that it depolarizes the ventricle. Okay, now simply what does right bundle branch block means? That means there is no conduction through the right bundle branch. What does left bundle branch block means? There is no conduction through the left bundle. So the terminology is not confusing at all. Okay, but we'll see what happens in each of that. But before we say them, we have to understand how normally ventricles are getting depolarized. So first up we have the septum, then we have the ventricular musculature, right? We have it like that. Okay. In the septum, what does this mean? I've told you septum is getting depolarized from left to right. Okay, so this is our right side, this is our left side. So septum is getting depolarized from left to right means this is the direction of septal depolarization. I'll explain what significance this statement has on our ECG. Okay, septum depolarizes from left to right. So this is a normal direction of the septal depolarization. After the septa get depolarized, we have the ventricular musculature. We have the right side and the left side. This left side definitely has more influence on the ECG because left ventricle has more mass and greater muscle mass. So it has greater influence. What does that mean? That means if there is depolarization at the left ventricle, it will show as greater amplitude. We're mainly talking about the amplitude here. Left ventricle will instill, or that will influence the amplitude more. When we are showing left ventricular depolarization, it has to be shown in a greater amplitude because that has been more muscle mass. Or when there is abnormality in the right side, it may be masked because the left ventricle exerts more influence on the ECG than right because of greater muscle mass. These are the two things that we need to understand before we try to decode what right bundle branch and left bundle branch block means. Also, one more thing, excitation spreading towards a lead causes an upward deflection or a positive deflection. Towards a lead, positive deflection. Away from the lead, negative deflection. So this is the third thing that we need to understand. So if this is lead 1, for example, or we are mainly talking this in terms of the precordial leads. So if this is V1, if it is coming towards the lead, then it is denoted as positive. Okay, if a wave is going away from the lead, it is denoted as negative. Okay, so when something is moving away from V1, it will be definitely going towards V6, right? So negative deflection in V1 would be positive deflection in V6. So this is towards, so that would be positive here. Hope that is clear. We'll see what does that mean in the coming up slides. Okay, so we have told three things. That is, septum is getting depolarized from left to right. Left ventricle has more influence on the ECG than the right ventricle. And also, if any deflection is coming towards a lead, it is taken as positive, or an upward deflection, or if it is going away from the lead, it is taken as a negative deflection or a downward deflection in the ECG. So now we'll try to understand what right bundle branch block means. So here is the thing. This is our right bundle and this is the left bundle. Now this side is being blocked. Okay. So how will the septa get depolarized? Septa usual direction, left to right. Left to right. Suppose you are looking at this thing from in terms of V1. Okay. You have to understand that the precordial leads are horizontal leads and the limb leads are vertical leads. So precordial leads or chest leads are looking at the heart in a horizontal plane. Okay, so V1 is looking from the rightmost point. Okay, mainly it is looking at the right ventricle, we can say, and V6 is just opposite. It's looking from the left side. It is more towards the left, right? So that is one thing you have to keep in mind. So when there is a right bundle branch block, how is the septa getting depolarized? Normally from left to right. That again can happen, right? Because the left side is normal only. So from left to right, it is coming. So when you are looking from V1, this septal depolarization seems like a positive way because it is coming towards the septal depolarization is coming towards the V1. So there is a positive deflection. There is a positive deflection, and remember that is septa. So the amplitude will be very low because we have a little bit mass only in the septum. So in terms of V1, the septal depolarization seems like a little bit positive deflection. What about V6? In terms of V6, which is looking at the heart from the left side. Okay. This is a diagram, don't get confused. This is the diagram and this is where we are drawing the ECG. So in terms of V6, what is happening? V6 is looking at the left side. So the septal depolarization, this septal depolarization in terms of V6 is away, going away, right? This is going away from the lead. So V6, the septal depolarization seems like a little bit negative charge. So this is our the first deflection. The first deflection is denoting septal depolarization. Septal depolarization. So in terms of V1, it seems like a small positive charge, a positive deflection. In terms of V6, it seems like going away from the lead or small negative deflection. So that is what this means. Now, the musculature, the right side and the left side. Here, since the right bundle is blocked, there'll be definitely current going through the left side, right? And then it has to go through the left side and then come from there to here because it cannot pass normally through the right bundle. So the left ventricle has to get depolarized first and then the deflection should come here. So V1 is looking at this thing. So the second part of this diagram, this QRS, the second part is ventricular depolarization. And in RBBV, the left ventricle depolarizes first. Left ventricle depolarizes first. Okay. This is in terms of RBBV, okay? Everything we are talking here is in terms of RBBV. We'll also discuss what LBBV looks like. So this is what RBBV looks like. So in second part, it is the left ventricle that is depolarizing first. So the left ventricle exerts more influence on ECG and has greater muscle mass. So there'll be a greater deflection that is being pronounced. In terms of V1, the left ventricle when it gets depolarized, V1 is looking at left ventricle and the depolarization spreads like this only, right? Through the musculature like this. throughout this. So V1, it seems like that depolarization is going away from the lead, and it is in the left ventricle, so it exerts a greater amplitude or greater influence on the ECG. So it is a larger negative deflection. In terms of V6, this left ventricular depolarization seems like coming towards the lead. So that seems like a greater positive deflection. Now the right ventricle will get depolarized after the left ventricle, because the current has to pass through the left ventricle and then come back, because normally the right bundle has to pass into the right ventricle, but now the right bundle is blocked, so it has to come after the left ventricle. Now for V1, this the third part is right ventricle getting depolarized, right? So V1 looks at the right ventricle, so like the depolarization is coming towards V1. So that is not as great amplitude as left ventricle, right? So it is this is a positive reflection, but not as great as left ventricle. So it is a little bit smaller positive reflection. Again in V6, the right ventricular depolarization, V6 looks at it like in terms of V6, it seems like the deflection is going away from the lead. So that is a negative deflection. So this is what we get in a RBBP pattern. This is called, so we'll name this wave. This is R, S, R dash. I'll explain why I've called it RS R dash. See, any first positive deflection is called an R wave. No matter how small or big, it's called an R wave. If it is small, you can denote it like, ideally you can denote it like a small r. So it's small r. Small or capital, the capital or small letter is denoting the amplitude. But R as such, the alphabet is denoting that it's a positive deflection no matter the amplitude. So the first wave, if it is positive, it's called an R wave. Second wave, that is following an R wave, okay, that is following an R wave and is a negative reflection, is called an S wave. No matter the amplitude, okay, that's called an S wave. Here it is a larger amplitude, so you can call it capital S. Now the second deflection, which is following an S wave, which is again positive, so that's again R, positive, so R. Amplitude is a little bit more, so you can call it capital R. Now this R and this R shouldn't look same, so you can call it R dash. So R is R dash pattern. So this is what we get in V1 in right bundle branch block. And this whole together, this pattern is called marrow. I'll say what it means. It M pattern in V1 and W pattern in V6. To just remember, we talk it like this, marrow. So RBBV, M pattern in V1, W pattern in V6. And hope it's clear how we have got M pattern and W pattern. Okay, so this is about RBBB. Now you have to understand how LBBB works, right? So we'll talk about LBBB now. In terms of LBBB, the left side is getting blocked, right? Okay, left side is getting blocked. So we'll see how that happens. So this is the right side, this is the left side, this is getting blocked now. Okay, this bundle is getting blocked. Okay, and we have our V1 here, V6 here, okay, looking from the left side, and we'll see what that happens. We'll see what happens in V1 and we'll see what happens in V6. Okay, so the first step, what is the first step? Septal depolarization. Again, septal depolarization. Septa should depolarize from left to right, right, left to right. But here there is left bundle branch block. So septa will not depolarize from left to right. Instead, the current has to pass first through the right and then pass back like that. So there is a slight deviation in what we see normally. Okay. So here what happens in terms of V1, septa should actually depolarize from left to right. Since the left bundle branch is blocked, it is going in an opposite direction. So V1 looks at it like that. So it is away from the lead. Away from the lead is negative. Since it is septa, it's a small amplitude. So it is a small negative deflection. In terms of physics, it is going towards V6. So it is a small positive deflection. Hope that is clear. Now second part. Second part is the ventricle getting depolarized. Which ventricle will get depolarized here first? Right ventricle. So right ventricle will get depolarized first. Right ventricle first. Okay, because the left side is blocked. This we are talking about LBBB. Okay, remember this we are talking about LBBB, left bundle branch block. Okay, so right ventricle will depolarize first. Now right ventricle getting depolarized. So this is the direction, right? V1 is looking from the right side. So this deflection is going towards V1. So that is a positive deflection. Okay, going up. V6 is looking from the left side. So that deflection is going away from V6. So that is a small negative, not much smaller, but smaller than left ventricular depolarization. So it's a small negative deflection because it is going away from V6. Now third part, what happens? After the right ventricle get depolarized, the current then pass from right ventricle to the left ventricle, not through the left bundle branch, but after the right ventricle through the right bundle branch get depolarized, the current then pass through the left ventricle. So V1 is looking from the right side, so that depolarization is going away. So that is a negative deflection. Since it is left ventricle, it's going to be a little bit larger in amplitude. V6, that deflection is going towards V6, right? Towards V6. So positive deflection, since it is left ventricle, it's a higher amplitude. Okay, so this is what we get. Now you can see, what do we get? It's a W pattern in V1 and M pattern in V6. You can remember it like William. Okay. Left bundle branch, what do we get? Left bundle branch, W pattern in V1, M pattern in V6. In right bundle branch, M pattern in V1, W pattern in V6. So remember it like Marrow and William. That's a simple mnemonic to remember all this thing. So remember that the septa depolarizes from left to right. Okay. After that, if there is right bundle branch, left ventricle get depolarized first. If it is left bundle branch, right ventricle get depolarized first. Okay. If a deflection is going towards the lead, it's taken as a positive deflection. If a deflection is going away from the lead, it's taken as a negative deflection. Okay, that was so far. And there's one note I want to remind. Right bundle branch block with QRS complex of normal duration is considered as normal. It's not always pathological. But left bundle branch block is usually always pathological. It's due to disease of left ventricle. Okay, this is what we have discussed so far. To summarize, RBBB we have in lead 1 RS R dash pattern. Lead V6 we have a broad QRS complex with a notched top, which is called as an M pattern. Okay, just remember it like this to mnemonic RBB, we have marrow, that is M pattern in V1 and W pattern in V6. LBBB, we have William, W pattern in V1 and M pattern in V6. This is the ECG. Here we have M pattern in V1. See, here is your M. See, RS, R dash, okay, and W pattern in V6, that is RBBB, okay, RBBB. Then we have W pattern in V1, this is our W pattern, and M pattern in V6, that is William, left bundle branch block, okay. We'll come to that was our right bundle branch and left bundle branch. Now left bundle actually has two divisions, that is anterior fascicle and posterior fascicle. Either of them could get blocked as well, or there could be bifascicular block. We'll discuss what each of them means. So this is our anterior fascicle and this is our posterior fascicle. So you can see the direction, right? Posterior fascicle conducts like this, anterior fascicle conducts like this, okay. See, anterior fascicle conducts like this. So this is anterior and this is posterior, okay. So I'll discuss here only what happens in anterior fascicular block. In anterior fascicular block, if this has been blocked, it has to conduct through posterior fascicle, okay, posterior fascicle. So when it is conducting through posterior fascicle, the cardiac axis will get shifted to the left, right? Because usually it is from -30 to 90. But if this is getting conducted through the posterior, then it is going beyond -30. That is left axis deviation. Okay. Okay, that is what happens in anterior fascicular block. Okay, now we'll see what happens in posterior fascicular block. Okay, so this is anterior, this is posterior. Posterior fascicular block as such is very uncommon, but suppose if there is a posterior fascicular block, what happens? This is getting blocked. Okay, this posterior side is getting blocked and it has to conduct through anterior. So usually the direction is -30 to 90, so it may go very well beyond 90. So that can cause a right axis deviation. Right axis deviation. So posterior fascicular block can cause right axis deviation. Okay. Okay. And now suppose if there is right bundle branch block. If there is right bundle branch block, left bundle is normal only. If there is right bundle branch block, left bundle would be normal. Then the conduction would be through the left bundle and the left ventricle has greater influence on the cardiac axis as well as ECG. So there will be no deviation or no axis deviation. The axis, cardiac axis would be normal because left ventricle has greater muscle mass and greater influence on the cardiac axis. Okay. So left anterior hemiblock, we told it's left axis deviation, and in left posterior hemiblock, when the conduction comes then through the anterior side, there has to be right axis deviation. RBBB, cardiac axis normal because left side has greater influence on the cardiac axis.